We're continuing our series of videos on the management of endometriosis, and today we're going to specifically talk about surgical management. Surgical management come in two broad categories. So one is fertility sparing surgery and the other one is surgery. In terms of fertility sparing surgery, again, there are two types. There's ablative therapy and there's excisional surgery. So this is how it works. In the pelvis, imagine the pelvis as a big basin, and in the basin are the organs, mainly the bladder at the front, the uterus in the middle, along with the fallopian tubes and ovaries, and the rectum at the back. Imagine on top of these organs sits a film of glad wrap that covers these organs and covers the basins and up the side. Endometriosis grows on this layer of glad wrap. The layer of glad wrap is called the peritoneum. To do fertility sparing surgery, what we're aiming to do is get rid of the endometriosis while leaving the organs intact. Ablative therapy works by using a hot instrument to burn the surface of this layer of glad wrap where the endometriosis is to get rid of the endometriosis. Excisional therapy is taking the glad wrap and peeling it off the organ that's underneath it, and then cutting out the endometriosis along with it. Excisional therapy is more difficult than ablative therapy. However, it does give you a more precise and more confident margin of excision. Whereas ablative therapy, you actually don't know how deep that endometriosis goes, whether it goes through most of the layer of that peritoneum or whether it goes through only the superficial layers. Often you only burn the superficial layers without getting it all. It comes back really quickly. Also, if you do pure ablative therapy, there is a risk that you judge your depth not accurately enough and therefore you burn the organ underneath. So for me, I mainly do excisional surgery for fertility sparing endometriosis procedures, but sometimes ablative therapy is the only way you can go. For example, if the endometriosis is on the back of the cervix, then it's easier to ablate than actually to excise. The issue about any kind of these fertility sparing procedures is that endometriosis does recur. The recurrence rate is about 10% per year and it's cumulative. So what we mean by that is 10% in the first year, 20% in the second year, and 30% in the third year. Most studies cap this recurrence rate off at 20 to 30%. If we move on to the non-fertility surgeries, this is where we remove the organs along with the endometriosis. Now, often really people talk about a hysterectomy. The idea behind it is that if we remove the uterus, then we remove periods, therefore takes away that terrible period pain that people have with endometriosis. It works for a lot of people, but for some people, even a hysterectomy doesn't get rid of the pain. And the reason for that is that a lot of the pain is driven by hormones, and the organ that produces the hormones are your ovaries. Therefore, as long as the ovary remains intact, in some people, that endometriosis will continue to grow. So for true fertility final surgery for endometriosis, you probably do need to think about an oophorectomy, so that is removing the ovaries along with the uterus. Even then, in some rare cases, endometriosis is still ongoing and they don't get the effect that they want. Our advice generally would be that because removing ovaries also brings a woman into menopause, and sometimes in young women it's early menopause, we do take that very seriously. It may be a good idea to give the patient a little bit of an idea of what early menopause would be like, both in terms of how they tolerate their symptoms, but also what it does to the endometriosis. So we can, for example, temporarily send a person into early menopause to mimic the effect of removing the ovary, see how well that's tolerated both from a pain perspective, but also from a menopause perspective. That's with injectable drugs like Zoladex, which is what we talked about in our previous video. So that's a very brief summary of surgical management of endometriosis, and next time we'll maybe have a chat about fertility options in the context of endo.